Good afternoon, everyone. My name is Nadia Murphy, and I'm the manager of the Voices 60 Plus Senior Advocacy Program here at Hospital for Special Surgery. And it is my pleasure to welcome you all to our conversation and presentation on talking to your doctor about your arthritis. Presenting today is Dr. Bella Mehta. Dr. Bella Mehta specializes in the care of patients with various rheumatic conditions, including rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, systemic lupus erythematosus, osteoarthritis, and has a particular interest in adult onset Still's disease. Dr. Mehta is actively involved as an investigator in numerous clinical studies focusing on disparities in rheumatologic diseases and has been the recipient of several awards for her research studies. Dr. Mehta's research reflects her commitment to achieving health equity, focusing on disparities in rheumatologic diseases. Dr. Mehta leads studies to identify and build creative approaches using big data to improve diagnoses and patient outcomes. She is an active member of associations for medical professionals in rheumatology. It is my honor to welcome Dr. Bella Mehta.
What is arthritis? Thank you. So what is arthritis? So arthritis is inflammation uh, affecting the joints or tissues surrounding the joints. And the most common symptoms that most patients come with is either pain, redness, or a hot joint, or swelling in a joint. This includes like 100 rheumatic conditions that can affect joints and other tissues. And most of them can result in pain and stiffness either in one joint or many joints. Some of these symptoms can come overnight, suddenly, or acute, or gradually over decades sometimes. So it could be chronic. Some of the rheumatic diseases may involve the immune system, but some of the, sort of arthritis, which is osteoarthritis, may not have any of the immune system systemically involved. So, 1 in 4 US adults have arthritis as a diagnosis. Um, okay, good. And about 33 million US adults have a diagnosis of osteoarthritis. So it's a huge population health issue too. And not only that it affects people, it also is a leading cause of disability amongst adults in US. So around 60 million patients have arthritis, 78 million are diagnosed with arthritis, will be diagnosed with arthritis in the next 2 decades. And around 25 million, 23 million patients have some sort of limitation because of arthritis. And again, in the next 2 decades, this is only growing. So we need to do something about it. Also, there's a high cost of arthritis in the US. I mean, it's 304 billion, which was estimated about a decade ago. But again, this is only increased. One is direct costs, which is medical costs, but there's also a lot of money that is lost in wages because people cannot work to their full capacity. So, what are the kinds of arthritis? Especially, when you go to particular doctors, they put in all these names. You want to know that there's many different kinds of arthritis. Osteoarthritis by far accounts for the most common cause of arthritis. 98% of the people have that. Whereas some of the other arthritis is rheumatoid arthritis, seronegative arthritis, which is psoriatic arthritis, ankylosing spondylitis, reactive arthritis, or arthropathic arthritis. So these are all inflammatory sort of arthritis, which can cause some of the joint symptoms. Post-traumatic arthritis is something that happens post injuries. Sorry. And then gout. So, osteoarthritis, like we said, is by far the most common kind of arthritis. A lot of joints can be affected, but the most common joints are the hips, the knees, the spine, and the hand. This is also called the degenerative joint disease, and traditionally thought to be wear and tear or mechanical, but there is a small or very slight inflammatory component to it that is being seen in newer studies now. Uh, I almost say that everybody has some amount of degeneration after the age of 40 in their joints. Them getting symptomatic or any issues with it is a completely different question. But some amount of wear or some amount of degeneration is happening as we age. So, what are the symptoms for osteoarthritis? Most patients, when they try to seek care, the biggest complaint that they have is joint pain, which is worse with use and relieved by rest. So, this is a key component. If the joint pain starts getting better with activity, most likely it's the other kind of arthritis, which is inflammatory. The other things that are there is tenderness, or when you poke on the joint, there's much more exaggerated pain. There's stiffness, there's bony swelling, joint deformity. Especially in the hands, those are visible bony swellings that you'll see in older adults. Joint deformity or joint instability, for example, buckling of the joint, and obviously functional limitations, as if, hey, I cannot walk up 3 flights of stairs or something of that nature. Again, more and most importantly, some of these joint pains are asymmetric. That what it means is that one side may be worse than the other, and there might be some bone spurs that make things worse, and decrease flexibility of the joints, in addition to swelling and sometimes even cracking, which is known as crepitus when the joints move. So there's some noises that can come. So again, most common sites of osteoarthritis is knee, hip, spine, and hand. Knee is the most common one and the most problematic one when it comes to disability. Usually one side is worse than the other, whereas hips too is usually one side is worse than the other when it comes to osteoarthritis. But if you've had damage for many decades, maybe both both left and the right sides can get worse. Spine, most common areas is either the neck or the lower back, which is the lumbar spine, which causes weakness and numbness in the arms or legs. Um, if there is any nerves that you think are involved, and there's like a lot of tingling, numbness, um, or problems with urination, then go to a doctor immediately or even an ER. So, some of these things are chronic, but when it's spine and then there's nerve impingement starting, that's when you need to see a physician right away. Um, Lastly, for hand osteoarthritis, it's usually bilateral, but the base of the thumb is affected a lot, which is right here. I'll show you a picture too. And with the base of the thumb, to be fair, it was traditionally something that we saw in older adults, but we're now seeing it in even young people because of a lot of phone use and texting. So, what groups are more likely to have osteoarthritis? And these are sort of high risk groups. So, women are more likely to have arthritis than men. This is symptomatic arthritis as well as some of the structural changes that happen in the joint. Second is older adults, and again, this is the perfect forum for this, have are more likely to have some sort of arthritis. Again, the reason I say this is there's many reasons for it. One of it is senescence and aging, and how the joint is bearing the mechanical load over a long period of time and thus having these small components of degeneration. Socioeconomic status is also known to affect it, um, and as well as there is some racial disparities that are known, In osteoarthritis, black non-Hispanic, white non-Hispanic, and multiple race non-Hispanic adults are more likely to have arthritis than Hispanic, Asian, or non-Hispanic adults, and Asian non-Hispanic adults, I mean. And the percent of adults with arthritis is increased with decreased urbanization level and is varied by region. Again, this is all stats from the US Census or sort of large data sets. Um, and this could be also a function of, more walking around in urban areas or whatnot. So these are just numbers. We don't know why this is the case, but you know, maybe being in cities have helped. Um, so one of the other things is weight. Weight is a risk factor, or increased weight is a risk factor. Obesity is one of the strongest risk factors for osteoarthritis in both men and women. At least conceptually, extra weight increases the loading on the joint and may trigger inflammation. So there's two parts to it. One is purely mechanical, because if there's 1 pound increase in weight, the knees have to bear 4 pounds uh, because all of the weight is gone down on the lower extremity joints. And weight gain during certain periods, like when you have drastic weight gain, may contribute to higher osteoarthritis rates. So that's another thing that we need to think about. And again, social and societal factors also shape osteoarthritis experience, financial resources, support systems, access to care, healthcare literacy. Sometimes women are known to push off getting surgeries until later in life because they have other responsibilities. So, those sort of things definitely play a big role. Um, and, you know, Women specifically have some more risk factors. Sometimes it's weight, but also the anatomy of the pelvis is shaped in such a way that lower extremity joints get more weight or more mechanical loading. Hormonal changes, especially perimenopausal, sports injuries, and we talked about some of the social and societal differences. So again, we talked about the anatomy, the hormones, which is perimenopausal. And then one thing I wanted to put in here is osteoarthritis and menopause is something that women experience right around the perimenopausal area, perimenopausal time. So estrogen drop during menopause may reduce joint protection. Weight gain adds to additional stress on the knees. Muscle and bone loss during this time can affect stability. So, what can help is regular exercise, which is strength training, weight bearing, aerobic, and stretching. All of these help maintain joint health. Pelvic floor exercises support mobility and overall musculoskeletal function, and staying active can slow progression of osteoarthritis and overall health. So, what are the exercises effective in osteoarthritis? A couple of them we mentioned. Mind body exercises are also known to be helping in osteoarthritis. It could be Tai Chi, yoga, Pilates, whatever be it. It not only helps osteoarthritis but improves sleep, anxiety, depression, fatigue, and bone mineral density, which helps the bones become stronger. Again, similarly, strength training, stretching, aerobic exercises, those help. Um, you know, One thing that if somebody asks me, I ask, especially older adults, I would say that I would avoid high impact exercises which may put additional load on joints. Um, but again, if somebody loves doing some a particular sport, that's totally fine. If they are just going to start out new, then that's when I would recommend, and they can do it with guidance. But I think the bottom line is to aim for 2.5 hours of moderate aerobic exercise and resistant training at least 3 times a week. So, what are the approved osteoarthritis treatments? So, a lot of them are non-pharmacological. Um, And even though it seems like, hey, we're not sure if this helps, they do help. They make a huge difference. One is obviously avoiding joint trauma, especially trying to do stretching before certain activities and cool down after, exercises and all of that. Um, Second thing is walking aid and knee braces. Walking aids not only help give stability and support, but also prevent falls, which is very important. And then knee braces are a game changer in osteoarthritis. They help unload the joint. And depending on how much or what kind of arthritis, there's many different kinds of knee braces out there, which you can talk to the brace shop or your physician who will be able to guide you on which ones might be best for you. But for starters, the sleeves that are available in every drugstore, um, I would start with that. And even if that is starting to make a difference, then you would go to some of the other much more specific knee braces. The next thing is orthotic shoes. So having the right shoe support makes a huge difference in osteoarthritis. Um, Again, a lot of podiatrists sometimes give it, but now there's all these companies out there which make very good shoes, and using one of those can be very helpful in providing stability. TENS units are something that you can get online, and people like it. It's mostly for symptomatic, like pain relief. It's not going to change the disease progression as much, I think, but it helps with symptoms. Acupuncture is something that a lot of people try. There's not a whole lot of randomized controlled clinical trial data on it, but it does help symptomatically, at least in the short term, for acute pain. Now moving on to the medications. There's not a lot of medications approved for osteoarthritis in terms of prevention, but it's almost like we're working on certain drug trials and working on many different uh, uh, research studies to try to come up with targets. But for now, for pain relief, there's NSAIDs, which is something that we can get over the counter, Motrin, Aleve, things like that. For patients who have like heart or kidney disease or stomach problems such as gastritis or reflux, NSAIDs should be minimized, and maybe Tylenol can help. Specifically for knee osteoarthritis, Cymbalta or duloxetine is approved and can be helpful. Some of the topical options are NSAID gels or creams, which is a Voltaren gel. Again, now it's available over the counter. Caspacin for localized pain. I have had patients who use icy hot or Bengay or anything that can help you symptomatically is recommended. Um, a lot of patients come and ask me, hey, should we go on hormone replacement therapy or HRT or estrogen? What my recommendation is, it may help the joints a little bit, but you usually don't use HRT for joint pain. Yeah, if patients need it for overall menopausal symptoms or overall health, then it's okay, but it's not recommended to be on it just for osteoarthritis, because the gain for that is minimal. Not zero, but not a huge amount. The other things are supplement, glucosamine or chondroitin. These are supplements that you are getting at every drugstore. A lot of patients take it. The evidence is really mixed, or if anything, saying that it doesn't help more than placebo. Sometimes some patients swear by it. It's okay to take it. It's not going to be harmful. It's just sometimes these are expensive and we don't know. It may or may not help. So I personally do not recommend patients to take those supplements, but some patients want to see if it's worth a try for them because in a subset they can work. The other thing is when some of the joints are very painful, we do offer steroid injections, which is glucocorticoids, and they do help in the short term for sort of it decrease inflammation in the joint and thus helps pain. Hyaluronic acid is another injection which is known, the names that are known is like Simvisc or hyaluronate or viscose or something like that. There's many brands for it. It has exactly the same efficacy as glucocorticoids. So since glucocorticoids or steroids are so much cheaper, we prefer that. Again, for some patients, hyaluronic acid might be preferred when glucocorticoids are contraindicated, or glucocorticoids can't be used for some reason or the other. PRP and stem cells have very mixed data. So at least the guidelines right now do not recommend it for the diagnosis of knee osteoarthritis or hip osteoarthritis. Again, it really depends. Sometimes physicians do offer it if they're thinking of some other tendon injury around it or something like that. Um, and there's definitely surgical options for knee osteoarthritis. Joint replacement surgery is um, a good option to restore function. Again, we don't have disease modifying therapies for osteoarthritis. A lot of the drug trials that came in the past decade failed. So at least this option of surgically replacing the joint might be a good option, so that we can at least get patients moving and not in pain anymore. So again, this is usually given to patients with much more advanced uh, joint damage. And again, partial joint replacements are also something that people do. So if it's only one part of the joint which is worse, there's a partial joint that is replaced. And once that is the case, in the future, if more things get damaged, then there's an option to upgrade it into a total joint replacement. That way, you're buying more time off the cartilage or the joint that is still there. And again, most patients will try physical therapy, maybe some orals, exercise, weight loss if they are obese, and NSAIDs or things like that before they directly go into a joint replacement surgery. Because some of these conservative measures also can be game changing. Using a brace, using a walking device, all of those things can help stabilize the joint and even it decrease the pain. With that, thank you so much.